Good morning, everybody. Welcome to another wonderful educational session sponsored by Bentley and promoted by Radcliffe to talk about branched endovascular aortic repair. I have with me some of my surgical mentors, Stéphane Hellon from France, Tim Resch from Copenhagen, and Prof Verhoeven from Nuremberg, who will be doing a live case. Later in the morning, we're going to see another case pre-recorded by Professor Hellon, just to give us all the tips and tricks that come with branched endografting. I'd like to start by thanking Bentley for their sponsorship of this session and for promoting really pure surgical education every chance they have, and also for Radcliffe for providing such a great platform for us. I think we'll begin the session by introducing my co-moderators, and I'll start with Professor Tim Resch in Copenhagen to introduce himself.
Hi, everybody. Great to be with you today. Just a heads up that my system is a little bit lagging and slow, so if I break off your questions and commentary, Tara, I apologize in advance. It's great to be here again. To see Eric perform another fantastic case and then have some great discussion. I think just remind the participants that you can ask questions online in our chat, and we'll try to bring those up as well. So great to be here with you guys.
Thank you, Tim. And Stéphane Hellon, Professor Hellon from France, from Paris.
Hey Tara, hi team, hi Eric in the hybrid room. It's good to be with you here from Paris. I'm really excited about this session. Thank you, Bentley, for organizing this very educational morning. There's so many we can discuss and share. So I'm very excited to see that live cases, and I have one of my own cases that I'll show you, and so we can discuss. You can ask questions during those cases, because the idea is really to share experience.
Thank you. Thank you both. So as my co-moderators have said, this is a session that's going to be inspired by you. Please feel free to ask questions in the chat, and we'll try and get to them and interact with them as much as possible. As well, during the course of the presentation, you're going to notice that there are some poll questions that come up at the bottom of the screen. We'll ask you to vote, and we'll talk about those at the end of the case as well. So with no further ado, I would like to zoom over to Nuremberg, where they're going to introduce the case and start showing us the magic that's happening in the endo suite.
Good morning, Tara. Good morning, everybody, and thank you very much. You said it all, so I'm very happy to try to show you a special case. And if Mr. Horst shows the PDFs, we can share our screen and go through the PDF very quickly. So I'll go back to the OR to introduce the team. So it's an 80-year-old male, as you can see, with a type 2 extent 2 thoracoabdominal aneurysm. He's otherwise fairly okay. Here a few images, no video because it's PDF. You can see the proximal landing zone looks nice, then becomes larger and larger and goes down. The iliacs are wide, but fine. We can go on. Here you have a view on the celiac artery, which is a bit the ugly brother. The SMA is absolutely fine, and both renals are asymmetrical, actually probably better for fenestrations. But we didn't want to wait too long. This guy has had his brother dying of a ruptured aneurysm, and that always puts pressure on things. It's actually the reason why he got checked and why the aneurysm was discovered. So we did a stage 1, and unfortunately the patient got corona after that. So we still had to wait, because the plan was, of course, to do him much quicker. And now we want to do a T-branch, and we've used a few T-branches lately. I'm not a big fan of the T-branch versus a custom-made device, because it always fits better. But I think the T-branch, of course, is the optimal solution when you want to go ahead a bit quicker. And we had 4 or 5 semi-acute cases in the last couple of weeks. Here, the images of the first stage. You can see the landing zone and angio and the first stent. And I think I also have an image of the distal area. This is the SMA, of course. The celiac doesn't come very nicely, but this is the distal stent, which hopefully is not too high and will have enough overlap. Otherwise, we will need an in-between cuff, of course. So that's it. And now we are at stage 2. We did a spinal catheter in the patient yesterday, and we had a few choices to make, and I would have loved to show you our upper approach. But the upper access, as you can see on the image, is not very nice. So we decided to do it from below. We did a percutaneous approach on the right groin for stage 1, and now decided to do this one by open means, and the left side is percutaneous. Okay, so that's it for the presentation. I'll go inside the room. I do apologize if my voice is a bit strange, but I catch the cold last weekend. Fortunately, it's not Corona. And with me, I have 2 colleagues from my department, Manuela Willem and Pavel Tysinski. We have an exquisite visitor, Mrs. Elena Garcia Rivera, something like that, from Spain. And we have our top sister, which is Sister Eva, who is our endovascular nurse #1. And the same time, we have our radiographer #1, Beate, who is also helping us with all her soul in these cases, and is now teaching another lady to learn about the fusion. So we are in position. We already did the fusion. Maybe we can show one image. Beate, kannst du mal das Mosaikbild zeigen? Und dann das zweite Bild, das dritte Bild erstmal zeigen. Yeah. So this was the access. Of course, you have to go through the previous graft, which is kind of important. Next image. And then you see that the access is a little bit angulated. On the right, we already have the Lundequist inside. And next, this is the introduction of the device orientation. Of course, you have the tick markers. You have to turn a little bit to know that you are well oriented. Unfortunately, the target vessels are not all in line with the standard orientation of the branches of the T branch. So I decided to deploy this one kind of in a neutral position, which means 1 o'clock for the celiac artery, 12 o'clock for the SMA, 10 o'clock for the right renal, and 3 o'clock for the left renal. We always look at all the orientations and see how we deploy the device. The level is also a bit, can we see the angio? It's interesting because the renals are asymmetrical, as you can see here. If we deploy nicely for the right renal artery, we will obviously be okay for the left renal artery, and we will be okay for the SMA because that's only 13 millimeters above the right renal artery, but the celiac artery is 30 millimeters above the SMA. So we need to take care of that. Next is built. So we did this angio, and this is where we are now with the single shot in the lateral view. And we're going to shoot another little angio just to make sure that the branch for the celiac artery is in a good position. So apnoe bitte. So we are in lateral view now. Oh, fertig? Apnoe bitte. Ja, bitte rufen. Angio. Up. Well, that sounds to be pneu. That sounds to be an exciting celiac artery. It's obviously not perfectly oriented, but the branch should be, let me look at the CT scan. there is a bit of calcification there. So we are about just all right, but we can't come lower to catch that celiac artery. Kannst du da mal scrollen, Beate? Okay, stop, go back. Okay. So I think I know that the celiac artery is about at that level where you see that little blush in the front. So at the first dots of the marker. So we should be about just fine, but we can't go lower. So I'm going to go back in AP and then do an automap to go back. Beate, can you put us the AP angio? Are we gonna deploy the graft? Yeah, based on this angio, and we adapted the fusion, of course. Okay, dieses Bild rüber. Yeah, so I'll do an automap to go on exactly that position, so to speak, and then we can deploy the graft. And sometimes it's very easy, sometimes it's a little bit tricky to deploy these grafts. And you can be as safe as possible, of course, and stay away from the branches. But I must say that I like to be close to the branches. Screen. So officially, I can't come down anymore, and I am above the renal. So I don't know if you see the fusion. Otherwise, we have to ask Mr. Horst. Richard, sorry, I always struggle with his name.
We can't see the fusion. It would be great if you could show us.
Okay. Richard, Herr Richard,
yeah.
Bitte die Fusion drauf tun.
The right one, no? Already.
Thank you.
Yes, it's okay. It's okay.
Yes, thank you.
Fusion ist immer das. Ja, sure.
I think it would be best if you get rid of the fluoro, leave the fusion, and so we can see Eric working.
Yeah, Stefan, at this moment, I have a little discussion point with myself here, because I think I'm in the back in the top, which is very strange, but. So,
you want to check with
what you're saying is that you need to twist the device a bit to get it reoriented.
Yeah, well, I turn clockwise now. I think this device, this is sub-screening. I think this device was quite torqued into the introduction system because I had to rotate. And when I rotated, I noticed a mismatch between the first three markers and the bottom tick. So now I'm going to show you a screen and I'm going to turn clockwise. And you see the three markers go clockwise. I'm turning back anti-clockwise and they go back to the middle. So there I'm fine. Now let me check my level again. My level is fine, but you see that distally, we will have to detorque this graft. So let's stay there for the time being. Open the graft a little bit. Let's see if this branch is fine. Let's turn left, okay. So the branch is in the front, so I turned clockwise a little bit. So I'm opening the branches now for the renal, and I am above the renal. I should be fine. Also with regard to the celiac. Actually, what we could do now is before opening the graft completely, but I'm going to open it a little bit, and you see the torque here. So I'm going to detorque this graft. Turn it clockwise to get it in position. So there was quite a torque in this whole graft. Now, hang on, stop screening.
So for those of you not familiar with Cook T-branch, he's looking at the three anterior markers that are above and below the branches.
Exactly. Okay, so let me do another little automap. No, sorry. Kannst du die Lateral noch mal draufsetzen, bitte? So we will go to the lateral image again. Yeah, put that on, yeah. And have a screen. Oh, no, don't screen, sorry, I need to do an automap. I will go in that position one more time. And again, there are cases where it's very, very easy. And there are cases where it's a little bit ugly. And this is one of those. Screen. Okay, so where are we? Doing
I think what you're showing, Eric,
overlay
is very important. Switching from AP to lateral, I think it's very important to not stay only in the AP view. This is a very important point you're showing us.
Yeah, I
will
completely
go
agree.
down a little bit, but now you should see it on the screen. I think from the height, we are a bit further away than I would like, but I want to keep it safe for the celiac artery. I think we could go down a little bit, but not too much because, well, screen, maybe just a little bit to come down to make it just slightly nicer. I think that should be fine. I think that should be fine. Okay, screen, stop screening. Sorry, let's go back in AP. Well, sometimes if the level of the vessels is fine, you can only concentrate on one vessel and then you're absolutely okay. But here it's more difficult. Screen. So let me open this graph now. Well, we came down quite a bit, but it's okay. So I'm going to detorque it a little bit. So turn anti-clockwise to get the markers in the middle. And as I said, there was a bit of a torque in this graph. Don't ask me why this happens. Okay, hold the graft. So we can actually deploy the graft completely. Let me, I'm sorry if I'm sniffing now and then. Screen. Okay. So the next thing, it's opening the diameter reducing ties. And now I like to open this graft very quickly. So that's it. And distally, I always look, especially when I torque my graft, I always look whether my distal stent is nicely open. Screen, because this is the moment you can still torque and detorque to have it completely. I think this looks good. So I can remove the distal attachment and we can go on. What we're going to do
this is a, go ahead, Stefan.
No, I was just going to state that this is the most important time of the procedure. If you get this part of the procedure right, then usually the rest of the procedure flies, or actually you're in a position where you can make it work out. And you need to take your time to correct it, exactly what you did, Eric, to really make sure that the orientation of the branches is correct, and switch from AP to lateral, and take your time, because if you do this part wrong, then the rest of the procedure can turn out to be an endo nightmare.
Yeah, I couldn't agree more. Unlike with TEVAR and BEVAR, deploying a thoracoabdominal graft is really a very staged process. You're almost deploying stent by stent, making sure that everything is okay in all views.
Zwei Finger drauf. So thank you for that, and I totally agree, of course. We are now removing the sheet, and I decided in this case to come from the Fluss im rechten Bein, Anästhesie. Bitte HB oberhalb 10 halten und Blutdruck oberhalb 125. So we now have flow in the right limb, which is nice. And we will introduce a gore sheet to make our to introduce our steerable sheet for the branches. Now the interesting thing is this guy is very tall, so I'm afraid with the system we use normally, we won't make it. So we have a different. We've used, like all of you, all the sheets. I think we now have this 71 centimeter 12 French sheet from which one is it now? Not the Fusta, the Oscar. We usually like to try it with the Fusta 10 French, but this will be short here, I'm afraid, and I don't like the 10 French. You can have a discussion if you want. But it's clear that we need better materials, perfect materials for this. What do you use now, Stefan and Tara, when you do it from below?
All right, go ahead.
Well, I mean, I only have Aptus sheets available to me, so we usually use, I think there's an 8.5 or the one step bigger.
We like,
but I agree the length is a problem.
From the sheet perspective, we liked the hard span very much, but it's only 8.5 French, and I like to have an indwelling wire in it, or a traction wire to keep the sheet in a 180.
So I think that if you are using the 8.5 French steerable sheath, what Eric just said is of paramount importance, is you need to have a wire inside to have enough support to advance your bridging stent, and it has to be 0.14 or 0.18 in order to have room to advance your bridging stents.
Exactly.
The problem
if you want, we can show that right now.
Great. The problem with that is you cannot get your steerable sheaths inside the branch. What I'll show you later on is with the larger Aptus sheath, which is a 16 French sheath, is the one that is initially designed to be used with the endo staplers. Then you can actually get yourself inside, and then I actually advance an 8 French 90 sheath through the branch and into the target vessel in order to have a real secure path for my bridging stent all the way to the target vessel.
Exactly.
And it also helps me to open the angle once I have pushed my 8 French sheath into the target vessel, so that the bridging stent will track really easily from the groin to the target vessel.
I do agree, and I do the same, Stefan. I like to play it safe. And the one thing that we always need to take into account that of course you will have problems with this sharp angle if you come with larger covered stents. So you need to take into account not only the inner diameter, but also the curve.
So I actually I used the heart span, the 8.5 heart span sheet for this. And in contrast to you guys, I don't use a wire indwelling to keep the shape of that. I actually cut the tip off that heart span. It's made for a transseptal approach. So the tip is like a guiding catheter, extremely soft, and it prevents you from actually hooking into the cuff of the device. But if you cut the first ½ centimeter of that device off, down to the perfusion hole, you can actually, I would say, in the vast majority of times, you can actually hook the 8.5 French sheath into the cuff. And then as you've done that, you don't need the wire because you have support by the cuff itself when you're advancing the stent. And you can actually play with the angulation inside that. So when you're up on the dome of the sheath with your covered stent or your bridging stent, you can just open the sheath slightly to get the stent passed. And at least in our limited experience, that works most of the time. So we never use a buddy wire to keep the shape of the sheath. If the 8.5 French doesn't work, I just go to the Aptus, which is 16 OD, but it's actually a 12 French sheath, and then that seems to work. But I think it just shows that all this is still very much an evolution. We're used to with fenestrated devices over the years. We're also trying to find the best option to do this, and slowly maybe we'll get there. Clearly, there's not an optimal sheath quite yet.
So what we're doing now is advancing a loop in a 9 French sheet into the Gore sheet. Okay, Licht aus bitte. Okay, screen. Now the one problem is that you usually don't see that wire very well. Bitte die Schleuse halten, dass sie nicht rauskommt. Screen. So the interesting thing here is that the sheet shows this sheet is 28. Beate, kann das Bild zu mir gedreht werden? There's our wire. You can see it. Okay. Festhalten. Bitte sorgen, dass diese Schleuse nicht rauskommt.
What do you mean by this sheath is 28? Are you talking about the length?
The Gore sheet, yes. 33 it is. Die Gore-Schleuse, die 22er, 33. 33. So actually with length, we should be even fine. 33, jawohl, Stefan.
Genau.
And so for those of you who don't do these every day, what Eric has done is put the main introducer sheath right into the main body of the aortic device so that he doesn't have to constantly recannulate that device, and it allows him to access the lumen easily. And then you've put a loop of an 014 or an 018, Eric?
Correct, 014.
014. And then you're using one limb of that loop to put the steerable sheath in.
Bisschen kippen. Perfekt. Okay, danke. Bisschen rückwärts, das manuell auch gucken. Sorry, I'm just struggling with the screens. That was not well oriented. Okay, screen. So now we are in there. And now we will go up and start business. Screen. Okay, so this goes out. Oh. Oh, muss das mit, Eva? Okay. Zieh das mal raus, vorsichtig.
And Eric, do I understand that you're going to start by the top range and then move down? Is that the plan?
No, I'm actually maybe going to see what happens now. And maybe we are in position, we can go from bottom to top, from top to bottom, but you're right, as long as you are. Just a moment, okay. So we now have the two wires. You would like me to go from top to bottom, of course. Okay.
Oh, no, I please do it the way you want to do it.
Zwei Klemmchen.
So it seems that the celiac trunk is going to be very challenging. So I don't know if you want to keep it for the end or.
Yeah, really well, I was even thinking, if the celiac trunk is giving me too much trouble, I may decide to do the celiac trunk from above percutaneously, but but I hope not, of course. Let me see where we are here. And
this could be a stage approach, and this could be like a perfusion branch to the sac for 24 or 48 hours, and there are many options to do those repairs.
Screen. Nicht zu hart ziehen, nicht zu hart ziehen. So you
this
see
is the Aptus steerable sheath that's bending now, or you call it heart spun?
Correct. This is the Aptus sheet. Actually, I'm not very happy because I see nicht ziehen, bitte. Because I see exactly. It's the first time I use this one. So the important thing is that you can turn it. So I'm not very happy at this moment because you see that there is a kink there.
Yeah.
Which caliber is that? Is that the 16?
That's the 12 actually.
8.5.
That's 12. The 12. Haben wir eine 8 oder 97er? Ja, die darf kommen. Gib uns inzwischen schon mal einen Katheter.
I find you have to be very selective about the radius of curvature of those steerable sheets, because some of them are a bit wider rainbows than you expect them to be. You don't have a lot of space.
And exactly the question I was going to ask, what radial curvature did you select? Because the problem with the T-branch is that at the level of the renals, you really have a narrowing of the endograft. And that's why I tend to go for the smallest radial curvature available with those large sheaths, which is, I think, 22, if I'm correct.
17.
It is a 22.
17, actually. There's a 17.
So 17. I have 17 for 7 French Aptus sheath, but I think when I go to larger ones, I'm not sure that I still have 17. Maybe you have it in
the heart span has a 17. The heart span has a 17.
That's great. Great to know. Thanks, Tim.
You see, I'm not happy with this sheet because it's already bending, which is not good. So we have a curve there. So we have a kink there, which is not good.
I think oftentimes these celiacs are the most difficult to come off right off that, the branch and the cuff comes off right at that angle from the thoracic aorta coming down. And then it's usually tricky to form that catheter.
So we're not
well,
even pulling on that sheet at all. So I'm
the
trying
aortic
to
angle
turn
in this
it.
case is really unfavorable.
Yeah, but you know, I didn't expect that sheet to kink there. You would expect it almost so. So I'm not sure we're going to make it with this sheet. We have
maybe
the
you
heart
need
span
to.
here.
Maybe you need to advance the dilator again to untwist
Get in another
the
position.
sheath. And
yeah. Okay. But then I need to get out completely, of course.
Yeah.
No, let's have the dilator. Mag das mal runter? Let's have the dilator again. So again, it's the first time I use this sheet. Yes.
Just a question for you guys who use this indwelling through and through wire to keep the sheath stable. Would it work to just use a standard flexor sheath, which is much less kinkable than to use a steerable in that setting? I'm asking from a novice perspective because I don't use that wire.
We've done it quite a lot with the 12 French ANL, which works well. But the problem is that it's short. It's 40. So
of course.
Here for the renals, it might just do it. The Fusta is 55 screen.
Yeah, I was thinking maybe use a 1070, a 1070, a 10 French, then you'll still have 8 French if you have the 14,000 wire.
We have the 8 French, 8.5 heart span here, and we have the Fusta in 55. Let me try to go up here and then come back and see whether we are in an easier position there. Let us see what
this is very interesting. What you're showing us is that those cerebral sheaths can be very helpful, but there's a learning curve, and it can also be a nightmare in very angulated anatomies, such as the one you're showing us. So this is a very challenging case you're doing, Eric.
Yeah, I found there's been a huge learning curve, and I haven't reached the peak yet. It's they're not easy.
We all don't have it.
I think the problem is often when you curve this device to get into the cuff and you torque it a lot, the stability in the body of these devices is really, really bad. And you create a kink in it, and it actually destroys the pull wire that gives you the ability to give it a curve, and then the sheath is busted. So you've gone through a fair amount of these during these cases.
I was interested by this sheet because it has a bidirectional deflection, and that's what I liked about it. Let me see where we are. We might as well go in lateral to try to see it better. You see that the sheet has suffered a little bit. Let me go in lateral, and if we can, we will do the SMA quickly. Okay, screen. So let me see what we have here. So you can see the branches, of course. Screen. Let me see. Okay, so let me see if we can turn this the other way around. This is what the sheet promised that it would do. But you can see the kink appearing. Okay, I can turn. Can you pull a little bit, Pavel? See ein bisschen?
It's kinking again, I think.
I think it's kinking again. I agree with you, Stefan. I will try to turn it. I'm not convinced by this sheet at all. So
yeah, you can
relax a
see the
little
twist
bit
there after the bend. It's going to be
yeah, that's exactly. So let me see if I can take this out a little bit.
I actually think it's broken, the sheet. You'll find that the wire is probably broken there. That's why the twist is there. So it's going to be difficult to advance anything through it.
Okay, let me have a catheter for a minute and see whether that goes through. If yes, we can insert a stiffer wire and then take a 7 or 8 French sheet in it.
When they break like that,
Yeah.
in your experience,
I haven't seen that yet, but it's the first time I use this one. Screen. Let me see if we can detorque that a little bit. And I think Tim is right. There is a kink that we will not get out here. So this sheet is out of order, so to speak. Let me see if the wire goes through. Screen. Otherwise, we're gonna have to move to another sheet. The wire is through, but the catheter, and I doubt we will be able to advance something bigger.
I think the problem usually is that the kink, when it does this, it ruffles on the inside. So even if you detorque it, the texture on the inside of the sheath, in my experience, just doesn't make it very usable anymore. So, but
yeah. So your clear advice is let's get out of here quickly and use another sheet.
I think you're going to make yourself more comfortable using another sheet, because I think the problem what will happen is if you manage to do this and get access, and then you won't be able to pass your stent and you'll curse because you spent 40 minutes doing this. So I would probably change. But Stefan, any comments?
Yeah, I agree. I'm just concerned that you will make your way to the target vessel and be in a position where everything looks good, but then you will not be able to track your bridging.
Yeah, exactly. I think the forces needed are so hard that I'm gonna take this sheet out and we may have a good look at it. Screen. Der Dilatator darf raus, bitte. Das darf kurz raus. Der Dilatator darf wieder rein über den harten Teil. I'm going to use the dilator to stretch it because I don't dare to pull it down. I think this sheet is not a success. I was interested because I saw it was 12 French and 71, and that was very close to the ideal one. What did I? Gib uns mal die Fußstar 1055 dann. Screen.
I think that there are many sheets available and many to come. I think that they were not designed for that specific purpose of doing branch cases from the groin, and we are trying to find the better compromise, and they don't all work. And this is what you've shown us today, Eric. I think you're in the celiac trunk branch. Yeah, that's great.
Yes, I was.
Eric,
I was.
Do you want us to?
Yes, absolutely. I'm going to try to get Please do so. I'm going to try to get a stable position with another sheet and then come back.
Okay, so what we can do is you can work your way with the other sheath, and while you do that, we will show the video and then come back to you a little bit later. Is that okay with you?
That's perfect. Thank you. Gib uns die Fußstar.
Thanks, Stefan. So now I'd like to introduce Professor Hollon from Paris with his pre-recorded case of 4-vessel branched.
So Tara and Tim, this video shows one of a similar case. And please jump in, give advice, give your tips and tricks. The idea is to discuss. You can see this was a case we performed in a lady that had a 60 millimeter type 5 thoracoabdominal aneurysm. You can see that the celiac trunk has a very tight stenosis, and that the right renal origin was from the aneurysm sac, but the left renal was slightly lower in a narrow portion of the aorta, in a non-dilated portion of the aorta. So unlike Eric, I had time to ask for a custom-made design, and so I asked for a graft with 3 branches for the celiac trunk, SMA, and right renal. and with a fenestration for the left renal. And this is the anatomy sketch. You can see the seal is just above that aortic kink, and we tend to aim at 3 centimeters of a proximal seal. And to reduce the spinal cord ischemia risk, I had my distal seal above the IMA in the non-dilated infrarenal abdominal aorta in order to keep the last lumbars and the medial sacral open. And you can always reline this endograft with the bifurcated endograft in the future. But for the time being, you reduce the risk of spinal cord ischemia. And unlike Eric, I don't use a spinal drain anymore. What I'm showing on the video here is the design of the endograft with the 3 branches, celiac trunk SMA and then the right renal, and a fenestration for the left renal artery. And I don't use spinal drains anymore. What we do is we actually wake up the patient on the table and put a spinal drain. It's a therapeutic spinal drain only if there's any signs of spinal cord ischemia. And prior to getting scrubbed, like Eric.
It's an interesting change in practice, Stefan. Tell me, how many spinal drains do you end up putting in?
Very, very few. And I'm only talking about a fragile patient undergoing open repair. I'm not talking about our young Marfan patient undergoing open repair, where we always put a spinal drain in. But for those old patients, we've figured out that the morbidity associated with putting the spinal drain the day before, keeping them 2 days in the ICU, and the whole thing becomes, I think, a major hit for the patient, while only putting drains in those that have symptoms reduces the whole morbidity associated with that. But to do that, you need to have a dedicated team that can position a drain in half an hour, 24/7. And fortunately, this is what we have. How do you feel about that, Tarantino?
Yeah, we're doing the same. We've changed our practice completely, but we've done it with an adjunct of NIRS. So we use NIRS in every case now, just to see if there's any way that we can predict the people who are going to need spinal drains.
I think that's great, and I'd love to see data on that. And in the future, that might be the way we monitor spinal cord ischemia. I'm again really thinking that this is the best way to do that. Now, what you're seeing here is from table side, after performing an AP and a lateral fluoro. The red image is the image from the spine from the pre-op CT, and I'm positioning, registering the diffusion on the bone mask. And once I'm happy with the position of the pre-op CT on top of the X-ray image of the spine, then I switch from the bone mask to the arterial mask. And you will see that in a second. It takes less than a minute from table side. This is what you're seeing here. So we've switched to the arterial mask, and usually I have the contour mode so I can see nicely my catheters and wires within the aortic lumen. And I have circles at the origin of the target vessel, and sometimes also circles within the target vessel to position, to locate the first division branches of my target vessel. And I think it's very, very important that you spend time on the workstation prior to starting those cases to appropriately select your bridging stent depending on the diameter of your target vessel at the sealing area, depending on the position of the first division branch and all that. Now at this stage, you can see that I have released the endograft, and I think because I don't see well on my screen the image, and I think that I have advanced like Eric did, a sheath, a Gore sheath, which is probably a 20 French sheath within the endograft, and then advancing the Aptus 16 French sheath, which Tim told us is in reality in the luminal side a 12 French sheath. I'm advancing it, and because this patient had a very narrow and very challenging a celiac chunk. Oh no, this is prior to actually inserting the endograft. Because of this celiac chunk that you will see soon with a very tight stenosis, I decided to pre-stent that celiac chunk, which is really not routine, but you will see the images. I was really concerned that I might not succeed in accessing this celiac chunk, and then I would have co-embolized it in order to avoid a type 2 endoly. So this is what I'm doing here, positioning my endograft, my C-arm in a lateral position. And we have preset angulation. You can see a small angio from the aptus sheath showing you the tight stenosis of the celiac chunk. I will fine-tune my fusion mask. And again, this is not routine, but let me ask you, Tara and Tim, do you sometimes pre-stent your target vessel when they look so ugly?
I will. I find myself doing it in renals more than celiacs.
I actually rarely do, but sometimes if they have subtotal occlusions, then I actually pre-stent them. But I mean, that's pretty rare. I wouldn't worry about a 50-60% stenosis because normally you get in, but if they're almost occluded, it's also a bummer if you have a fenestration and you've planned for it on a scan that's now 2 months old, and that 90% stenosis becomes an occlusion, and all of a sudden you have a hole in the graft, which might be difficult to redeem from an endoleak perspective if you have to close it. So you just have to be careful when you do pre-stent stuff. You just have to be careful so you don't protrude those bridging stents into the aortic lumen, because that can cause problems, of course.
Great. So this is exactly what I did here. It was a near-occluded celiac chunk, and so I decided to reopen it with a bismuth. Cobalt chrome, I think it is 718 I'm using here because the profile is really nice, and you see how it tracks well through this very tight stenosis. And again, I actually really checked my fusion mark and this circle at the origin of the celiac chunk in order to make sure that my stent would not protrude too far within the aortic lumen. So I'm opening the bismuth here, and then you will see that the selective angio to check the celiac chunk shows that it's now nicely open. So now I felt good about it. I'm happy with the position of the stent. And the next step was actually the same maneuver at the level of the right renal artery, because on the pre-op CT, that right renal artery looked really bad, and I was concerned that I would also have that issue, and Tara was telling us that she sometimes also is concerned about her renal arteries. So you can see my aptus sheath is now in front of the origin of the right renal artery. I'm pushing a Terumo wire and then a KNP catheter within the renal artery. I think something important here is when doing on complex cases, you can actually get into first an early division branch of your target vessel. You can get in an ilolumbar thinking that you're in the renal artery. You can do very stupid things, and I've been there many times. And so that's why I always check that I'm in the main chunk of my target vessel before advancing a stiff wire. This is what I'm doing here with a Rosen wire, and in those procedures, the Rosen wire is my favorite one because it's most of the time atraumatic, and this is what I really like about it. And then I'm shooting a selective angio, and finally, that renal artery looks not that bad, and I decided not to stent it because I was concerned that in a small diameter target vessel, pre-stent and then reposition the stent might actually become more difficult than just go directly because there's no very tight stenosis. So at this stage, I decided to stop working on that right renal artery and decided to insert the endograft. Would you agree with that, Tara?
I would. You know, something I tend to do is actually leave the wire in with a balloon on it, just in case I need to do another angioplasty once the device gets in, if anatomy has changed. Do you ever do something like that?
Yeah, I think it's a kind of a body wire that you would leave in position. I do that a lot in dissections for the target vessel that are perfused from the false lumen. So I fully agree with that. So what you can see on the screen now is that I'm making sure that the orientation of my endograft within the delivery system is correct, and then I'm inserting the endograft over a Londoquist wire that has been advanced into the ascending out. So the endograft is now getting inserted. And we did this case completely percutaneous with a ProGlides system. We now have Pro styles, much cooler. The color is really nice. And I'm advancing the delivery system through the groin and then into the expected delivery. And this process here, because there's a fenestration, will actually focus on nicely positioning the left renal fenestration in front of the origin of the target, so making sure at the top that I have a nice sealing and all branches are getting open. And like Eric did, every time I open one stent, I check the rotation of the endograft and the height of the endograft, and I fine tune it if necessary. You see step by step, and maybe on the video, I'm not showing it, but I actually really very often switch from AP to lateral to check that the branches are facing towards the target vessel, the visceral arteries, and not in the back of the aneurysm sac, which happened once. And so I had this issue. I really double check.
And I think it's important to really dwell on that, because not only does it make a difference in terms of how easy it is to get your branch stents in, but it actually makes a difference in durability. If you have untorqued branch stents, they're less likely to occlude or fracture over time because there's less stress on them. Wouldn't you agree?
I really agree. That's a very important point. Now, what I'm doing here is getting access from the control groin with a 6 French sheath through the fenestration into the left renal artery. And you can see here my catheter advancing over the Terumo wire, and then I'm going to exchange for a Rosen wire. So for fenestrations, when I have the fenestration really abutting the origin of the target vessel, I tend to use B-graft peripheral bridging stents. But for my branches, where I have a bridging stent that will be within the aortic sac lumen and then into the target vessel, I tend to use B-graft plus. And I'm really happy with those B-graft peripheral for fenestrations and B-graft plus for branches. Sometime I will use B-graft plus for fenestrations when my fenestration is actually a couple of meters away from the origin of the target vessel. But I would not recommend using B-graft peripheral for branches, because they have not been designed for that purpose, where B-graft plus are really a perfect platform to bridge the branches. I think here I'm advancing a proximal endograft because I was not happy with my sealing zone at the top. So obviously, to extend the sealing zone, a short thoracic endograft is advanced here. I just need to make sure that I'm not covering the branch to the celiac chunk while doing that. This is something that I think most of us have experiences. We sometimes are shorter than expected, and so you always need to have off-the-shelf devices to reline your endograft at the top or at the bottom in case you don't get it perfect. Is it something that you always plan, Tim and Tara?
Yeah, I think having good ancillary equipment around is imperative, because you never know where you're actually going to land and if you need to extend another stent or so up. Now, Stefan, we have a question from the audience asking about how you choose the right catheters to not damage vessels or injure vessels. Can you talk us through your catheter choices?
Yeah, so it's actually a very complex process. It is taking a KMP catheter and going into the target vessel, which works for 95% of my cases. Now that we've switched to using steerable sheaths almost for all our cases, so I just put the KMP inside my steerable sheath, and the steerable sheath will give you the good support. And the KMP is a 5 French. Looks like a vertebral catheter with the beacon tip. It's a cut catheter. It's really nicely tapered, and in my experience, the 5 French, you can really nicely control it, and it, in my experience, is very atraumatic and nice. Here you can see I went through the previous stent. Do you use many other catheters for your cases?
I think you tend to get used to using 1 or 2. I love VS1 when I'm not using steerable sheaths, so I find the VS1 to be my workhorse catheter. What about you, Tim?
So I think, like Stefan was pointing out, I think with the steerable sheaths, we've just almost eliminated all catheters. I actually use a Navy Cross catheter for almost everything if I have a steerable sheath, because it passes through all these target vessels so nicely, and it's very atraumatic. I mean, it's rare now that you select, or at least when I do these cases, it's rare that we select target vessels without a steerable sheath. And then if you have a steerable sheath, the catheter matters less. The shape of the catheter, which we were all taught so important, actually matters much less. So I use a Navy Cross, which is actually a CTO catheter for lower limb.
What I find is an important component of a catheter is to be able to see the tip, though. So as Stefan was saying, the beacon tip is important. It is useful to see the catheter. And sometimes that can be challenging in larger patients.
So what you can see here is that I have access now through the branch, the celiac trunk, the pre-stented celiac trunk. I have advanced an 890 sheath inside, and then injected contrast to locate the bifurcation of the celiac trunk. And now I'm advancing a BEVAR plus, which is an, I think, 8 or 957. And what is really nice is you can really nicely see that target vessel, that bridging stent, sorry, and I'm going to inflate it.
I think that answers another question that we've just had from the audience about why we're using balloon expandable stent grafts instead of self-expanding stent grafts.
I tend to use more and more balloon expandable stent graft because they're actually very nicely to track from the groin through those steerable sheaths. They are always perfect for our visceral target vessel, for the celiac trunk and SMA, and in most cases for the renals. But I would actually, in some cases where you really have very upward going renals, tend to favor maybe a more flexible device, but then you need to secure it on most of the time on both ends to keep it in place. And I'm talking about the BEVAR option. So the balloon expandable would be my first choice, having in mind that if it's in some very specific anatomies that you can find with type 2 thoracoabdominal aneurysm, when the aneurysm is really sitting on the renals, you might want a very flexible and long platform, and this is where I would use the BEVAR. So it's very funny because while I'm talking and presenting that case with the Bentley bridging stent, I actually got an email from the GEVT telling me that they just accepted the 3-year follow-up on the Bentley B graft with fenestrated endograft. So it's so sometimes everything lines up. So it's a good news. So now you see that I've done exactly the same thing. The steerable sheath is inside the branch to the SMA. I have advanced a catheter, and I'm checking my position in the main trunk again of the SMA, because you don't want to push a stiff wire inside one of the division branch of the SMA, because you can end up with a false aneurysm or a dissection at that level. You can see the 8 French 90 sheath has been advanced within that SMA, and now the BEVAR plus is inflated. And you can see that I make sure that I have a full overlap with the branch. And you can see that I'm a bit short on the SMA side. So now I need to reline that BEVAR plus with another bridging stent. But now that I'm within the target vessel, I don't need another BEVAR plus. I actually decided to add a BEVAR in addition to the BEVAR plus to get more seal inside the SMA. Now I'm here getting access to the right renal branch and then to the right renal artery.
Stefan, we've had another question from the audience, if I may interrupt you, just asking about the femoral approach, because it seems like we're seeing 2 cases now that are using kind of a total femoral approach for thoracoabdominals. Is this the new standard? You know, like are these reticulating catheter or sheaths so novel that they've changed our practice? I would say yes. And for the last 3 years, I think I've done 90% of my branch cases from the groin. I think that we now have the tools to perform that securely. We now have a workflow that is has been really clarified. And the nice thing about it is that we are most of the time much faster, and we get a better protection against radiation. I'm talking about us, a physician, because you're working from the groin, so you have the shields, the lead aprons, everything is perfectly positioned. So I tend to think that it's the new standard, and I again would think that it's suitable for almost 90% of the cases. Would you agree, Tim and Sarah?
Yeah, I absolutely agree. I think it's been a gradual switch, but once you get the hang of it, it's actually, for many reasons, as you stated, easier to go from the groin. I just think it's important that, you know, like everything, you use the tools you have in your toolbox. So if you have a target, and we discussed that in Eric's case, the celiac, if you have a target vessel that it is exceedingly difficult to get from the groin for various reasons, don't forget that it's not forbidden to use an arm to do that. And I think, having said that, and that hooks up with the discussion on branch stents, now going from the arm to stent with a balloon expandable stent is usually an 8 French sheath, as opposed to using a very large self-expanding stent there where you have to go to 10 or 11 or 12 French, which is significantly more. So I think it sort of all adds up to do that. And I also think now to use the arm approach is good for staging these cases if you want to go for a difficult celiac. But yes, femoral approach for us also is basically the only way we do it. So.
Yeah, I think I'm slightly more agnostic than both of you, but it's probably because I'm earlier in my learning curve that I still see the arm as a viable and equal alternative. I've never really had that much problem with it, but I agree the radiation dose for us is lower if we can go from the groin. So it's aspirational to be femoral all the way.
So Tara, let me just add that I do it from the groin, but I always leave the axillary available for a puncture if I struggle from the groin. Having said that, I haven't used it yet, but I always have in mind that I might not make it from the groin. I think it's nice to have both approaches available, and sometimes if you don't, the nice thing about branches is that if you don't succeed the day of the procedure, you can always come back from a different approach. The branch will keep on perfusing the sac and the target vessel. And so this is the end of the procedure. We now have positioned the branch in the right renal artery and its bridging stent. We have a now positioning, I think, the stent in the left renal artery. And so we're almost done with that case. This is the B graft through the fenestration in the left renal artery. What I do is every time I actually inflate one of those bridging stents, before deflating, I start pushing the sheath, and so that I can advance the sheath back through the bridging stent, and then advance the flaring balloon here, which is a 9 or a 10 by 2. And you can see soon the flaring balloon will be inflated. We try to put some pressure on the balloon, on the shaft, so that we can actually flare the top and the bottom of the bridging stent. And then I'm going to go back in again with my 6 French sheath to check that we have a good perfusion of that left renal artery, no endoleak, no dissections, no issue. You can see the kidney is nicely perfused. So at this stage, I think it's time for a completion angio, and then a non-contrast cone beam CT to check my bridging stents, which I will do very soon. So here is the completion angio. You see the endograft and the branches nicely perfused, and then the cone beam CT is performed. This is really routine for us to do that 3D imaging at the end of the procedure, because then if there are any kinks in one of the target vessel, if there is no good position or overlap, and this, you can see the quality of the cone beam CT is really helpful to depict one of those. See here the celiac trunk bridging stent within the previous B smoothed and the SMA. Finally, the right renal branch, and then the left renal fenestration. Do you also routinely do cone beam CTs, Tara?
I don't, and I know that you and I disagree on this, but I find if the case has gone well and my completion angiogram looks okay, then I tend to not commit the extra radiation dose on the day of surgery. I would prefer to do it a month later when the CT scan will potentially give us some more information. So I don't do it every time. Is that heresy?
So the idea of doing that is having a 3D imaging. We can actually discharge our patient on day 2 with already 3D imaging plus ultrasound, and then we will get them back with a CT scan 6 or 8 weeks after the procedure. But with that 3D imaging, I'm 100% sure that there's no big issue that I have missed on a 2D angio. But I mean, this is a debate that we can have at another time. I think it's good to see that there are many ways of doing those cases. So that's about it. I wanted to show you. The other thing that is important, as you see, we've used a lot of collimation. We are driven by fusion. We actually do all our cases on low dose mode. And so the added DAP for just the cone beam CT is only 7. So it doesn't really change much to the overall radiation cost of the procedure. But it really depends on the system you have and how exposed your patients are to radiation. So, but I just wanted to show you that case that was interesting because we had to pre-stent some of the target vessel. We matched branches and fenestration, so used different bridging stent, B graft peripheral for the fenestration, B graft plus for the branches, and show you how they track really nicely through steerable sheath from the groin. And I think, Tara, we might want to go back to the OR to check what's going on, because Eric is really moving forward fast.
Absolutely. While we're moving back to the operating room, we just had another question from the audience. Is there any contraindications to the femoral approach, in your opinion?
You know, some very tortuous iliac and infrarenal aorta can be an issue. Having said that, because we get that system within a longer sheath that straightens everything, most of the time it's not.
What about endo-endo conversions
narrow...
if you have a failing infrarenal graft in place?
Yeah, I mean, but you know, there's always ways around. Maybe the case will not fly the way the case, such as the case I just showed you, but there are always ways around, and I don't see major issues. I tend to come from the top when there are a very complex dissection. I need to go from the true to the false, and sometimes it's difficult to do that from the below approach. But apart from that, I don't see real contraindications to using the groin approach with cerebral sheaths.
Mm-hmm. Great. All right. Well, I think Eric has said that we can rejoin him in his operating room. Professor Verhoeven, are you there?
Yes, Professor Mastracci.
How's your day been, Professor Verhoeven?
It's been an absolute pain, and I'm going to try to show you why.
I've been watching you out of the corner of my eye. You've been doing a great job.
That's good. Well, I'm going to show you why we struggled, because it's interesting. Actually, this Fußstar is not doing exactly what I want. Try to keep it nicht mehr so hart ziehen. Let's go back and show you what we did. Geh mal zurück auf die SMA. So we geh mal zurück bis zur SMA. Yeah. So, yeah, diese. Zeig mal, ist das ein Single Shot? Yeah. So we use the Fußstar. Stop. Yeah, okay. So here you see the introduction of the 7 French sheet.
7 French.
The Fußstar is 10 French and it's 55. Oh. And it's a 7 French ANL that goes inside. Now, stop screening, go back. Zurückgehen, bitte. Mosaik und zurückgehen, bitte. Eine weiter, unten links, ja, das müsste ein Single Shot sein, yeah. So here, this was the catheterization, which was fairly easy, but I didn't make it to turn my sheet to the front. So that's the one. Next Bild. So then we catheterized the SMA, which was unexpectedly a little bit ugly. I did it with an 18 wire. This is just a single shot. Next. So this was the catheterization of the SMA. Next. Then we come back to this angio that I showed you before. And the sheet went in reasonably well. So we had no kink in our in our Fußstar. We made an angio to decide where we were. Next, here the sheet was even too deep inside. That's the entry. We decided to go to the last marker to really cover, and we decided to use 2 stents. And interestingly, and some people may bug me for that, I put in the distal one first. Next. And here we struggled. Controversial. Next one. Next. This is the advancement of the first stent, and believe me, this is an 857. I struggled because this is, of course, narrow in this curve, but we made it to get the stent inside completely. Next, and then we deployed it. Next. And then I removed that 7 French sheet and decided to go naked. Next. And here I think next, I think we were lucky because this could have gone horribly wrong, but then I would have inserted the sheet again. So here it's more luck than skills, I think. But everything went in.
Well, I think it's a calculated risk, right? But I agree, this wouldn't be the way I would do it my first time.
No. Next. And this was the end result. And next, and now you have the angio.
Really nice
And now
overlap. How did you decide how much overlap you needed?
Well, I chose 2 long ones, and I realized that a shorter one would have gone around the curve easier. So I would always prefer to have a 37, but then you jeopardize on the overlap, and there is nothing more important than overlap. Screen?
That is true. Overlap in the diamonds are a girl's best friend.
Exactly, exactly. So here now we have the sheet in an acceptable position. I'm still with an 18 wire, and we're going to try, oh, that's the wrong catheter, sorry. Den Berenstein, bitte. And now, while we are here, but I'm not going to lose time on this, if I struggle, I will do the, just a moment. I thought so. The wire went through one of the holes of the catheter, but that's not a problem. If I struggle, I will probably do quickly the 2 renals. But if
you can always do the celiac another day, right?
I can do whatever, but I would love to do it now, I must admit. But it's the ugliest vessel, of course. I'm not expecting too many problems with the renals, because now we struggle with length issues. But as you can see, even in this screen, in this 190 guy, we are 90 plus, so almost 2 meters. We are kind of reaching the length that we want with the 55. Now let me think. This is the celiac branch, which means that it's at 1 o'clock, correct? It is correct. Okay, screen. Let's see where we are here. We will pull down our sheet in a minute, but I would love to first get into that branch. I'm on the collar here, as you can see. I will probably bring back my sheet, but bring down my catheter. So, and now I have a bit more option to turn, but I don't want to be in that niche there.
You're getting a really nice perpendicular view of that branch, which makes it easier to cannulate.
I always do, but you see, we have a niche here. We have a kind of a little angle, a little shoulder that makes it ugly. And that's the problem.
So while you're doing that, I'm going to ask Tim for some questions from the audience. So in your experience, Tim, does BGRAF and the BGRAF Plus always go kind of easily through the steerable sheets? Does the small caliber of them make them passable?
No, they don't. And especially like Eric is pointing out, especially if you use the long ones, if you use the 59, 57, I think they are, with the BGRAF Plus. So that, of course, on labels goes through an 8 French sheath. But if you have a tight curve, that can be extremely challenging. So normally it goes. You just have to have a lot of patience and go slowly. And then once you're over the dome, it usually passes through. One trick is the way we do it is again to engage the cuff. Once you're inside the cuff, you can actually then allow yourself to open the curve of the sheath a little bit, because it's supported within the cuff, and then it'll track a little bit easier. But I'd be the first to admit that there is a significant amount of resistance, and there have been times when it just wouldn't go over that bend. So and then you're sort of either you choose to try again with a stiffer wire or some other manipulation, or change your stent to a shorter one, like Eric suggested, which can work, or you can move up to a larger steerable sheath like the Aptus if it's if you feel that's appropriate.
Great. And
I think the important thing when you do that and when you do feel resistance is that you take it nice and slow. If you try to push hard and go fast, 2 things are going to happen. One, the stent wants to not sit on the balloon. It comes off the balloon because you're pushing too fast. And the other one is that you crinkle the shaft of the balloon. So you basically destroy the shaft. So once you start feeling resistance, just be patient and push slowly.
Yeah, those haptics are so important in endovascular surgery, just getting the feedback from the catheters and things. Really, that is, I think, the learning curve, is learning what you're feeling.
Contrast.
So Eric, I noticed that you've gotten into the celiac branch.
I'm not sure, but no, I think I'm not. I need to, well, I am in the branch, of course, but I was hoping to also be in the celiac artery, but I hope this is not occluded now. Because as you noticed on the CT scan, it is a very small vessel. But I went through the branch and now I'm in a actually fairly good position according to the fusion for the celiac artery. Let's see how we do. Screen. I all the time like to think that I'm fairly close, but as long as I'm not perfectly in, I'm nowhere.
And the thing is, sometimes in these large thoracos where there's thrombus around the celiac, you can make yourself a false path through thrombus, yeah. And it really feels like you're in the right place, but you're not, doesn't it?
Thank you for mentioning that. I'm joking. Well, I hope my fusion is correct. The fusion was not correct for the SMA, and that was because of the fact that the SMA had such a big orifice. So
this fusion, I think, has changed the game for thoraco repair. And there are a bunch of different fusion systems that you can use, but as you've alluded to, having one that you can kind of manipulate, like Stefan showed and like you're doing, to change as the aorta deforms is really important.
I couldn't agree more. It's sometimes a game of patience, especially if you want to attempt these ugly vessels, but this is something you have to be prepared to. You know, there are vessels that are very easy, where it's just, you know, the routine, but there are vessels where it's really ugly, and this is one of them. Okay. Yeah. Yeah. Die ist zu vergessen. So we are in, of course, screen. We're gonna do a little shot. Okay, that's fine. We have a very small hepatic that goes off, as Manuela points out. And I doubt I would be in that one, but it's not impossible. Now, if we look at the parts, I think we are in the correct vessel, but we're gonna check that in AP for a second. I don't know if you remember the SMA angio, but we had quite a lot of collaterals through the celiac or to the celiac screen. Let's see where this catheter is now. It's okay. It's in the splenic, so it's okay. So we are fine. We can go back. Okay, let's have a Rosen wire. Which wires do you like to use, guys, for the Rosen? Which wires do you like to use when you do the branches from below? I stopped using the Amplats because it's too stiff.
Yeah, I never use, if I don't, you know, I use the Rosen primarily, and I would think primarily because it's the only one almost available. For the SMA, I use the Supercore wire. I think it's a very good wire. It's got a 20 centimeter softer tip, and it's good for the SMA. Unfortunately, it doesn't work for the renals. So I think Rosen wire most often. We've tried a couple of other wires, and I think there's not a really good one. I used to use the Jindo wire from Cordis, but they discontinued that wire for some odd reason, probably because I was the only one in the world using it. But
you and Cressy. I inherited a lot of Jindo wires in my last job.
Yes. they were fantastic for the renals. That was a renal
screening.
wire. So
Gut gegenhalten. Gut gegenhalten. Ne?
actually, that Rosen wire I don't find it's a very floppy wire. The chain tip is not very good. So, but I think that's another step that we need to produce better wires for these cases, because I think
You have the
we don't
wire,
have optimal
Elena?
wires.
Yeah, my issue with the rosin wire is that it ages very quickly. It's good the first
Nochmal.
2 or 3 times you pass it through a catheter, but then after that, it just becomes less, has less integrity. It ages quite quickly.
It's because the coating is from the 70s. So, you know, nobody in their right mind would buy a running jacket that's from 1975 because it's a piece of not so good anymore.
Unless they want it to look stylish.
That's true, but they would probably use updated fabrics anyway. So that's true with the wire as well. The Rosen wire is about 37 years old. So the coating is maybe not the most modern. Sort of like the Amplatz wire, actually, which is Teflon coated, which also has a poor durability in use. Once you kink it, it's broken and it starts shaving off. So.
Now, we have a question about stent lengths. Go ahead.
No, I was just saying, I think that ultimately over time, we probably will move more towards 018 platforms for these once these stents. I mean, we have self-expanding covered stents now to come down in size to 018 platforms. So I think that as we progress, we might go that path. And the multitude of wires are just so vast for the 018 platform.
Screen. Nicht ziehen.
And do you think they'll be stable enough to go through, for example, the anatomy we're seeing here with Eric?
Well, I think, again, it's the stability that we need is a result of the stents and covered stents that we use. So if you compare a modern covered stent or a flexible modern balloon expandable stent to an old one, the new ones are much more flexible. So now we don't need to use Amplatz wires anymore because we're not using fluency and so forth. And I think the same, if you start using 018 platforms, you can use there are coronary covered stents that are 5 and 6 millimeters in diameters that go over 14,000 platforms. And obviously these are extremely flexible and require much less wire support. So I definitely think more of that will come.
Wir brauchen ein 8er Ballon.
Wise words from a veteran.
Are you talking to Tim, I assume?
Oh, both of you. And how are things going in the celiac, Eric? It looks like you're winning.
Well, I'm taking a shortcut, and it's not a category. Don't do this at home. But I tried to get the previous 7 French sheet. Diese Schleuse kann weg, die ist nicht mehr gut. And it was horrible. So I decided to go naked, and based on the CT and the fusion, I know exactly where I have to go. So I'm going to try to shovel a 757 B graft plus in. And once I'm there, I will go distally where I want to be because I want to get this vessel done if I can.
So I think this going naked, as you call it, is something that you can do if you have experience, because you do understand what it feels like to strip a stent off a balloon. Moment.
Screen.
You would think that, but sometimes you strip it on the way out or something else, and it can actually cause you a lot of pain and a lot of extra work. I was doing a case the other week where I managed to drop not 1, but actually 2 stents, and that made up for almost 25% of the procedural time for that case, just snaring and getting these things out. So, yeah. You have to do it, but you see.
The bad news is we will need a second one. 737 fertig machen. Oder 837, noch besser. So what I did here is use a 757 naked, as you can see. Screen. I may go just a little bit deeper. I want to stay in the branch to have contact, because this is always safer, of course. And then I'm going to hopefully get an 837. So I don't need to balloon it proximally. Screen. I'm going to inflate this one quickly. So we are past that kink of the of the celiac, as you can see. Now, Manu, if you can get this one in position, keep it there, because I need to pull now, which is ugly. But with that, we will have done the two ugly vessels. Ugly because you have to work in lateral, and ugly because the celiac was ugly. And then we can reposition and go to the renal arteries. So we're going to advance from 837 into that 757. And if we achieve that little kink, I'm not going to do anything about it. It's a BEVAR plus. It's the best we have with regard to radial force. And this is nature. It should work. But I don't want to overinflate, 38, overinflate or overstretch this. I mean, this is the natural part.
We've actually,
when you're using
I totally agree with you. To see the BEVAR plus specifically in the celiac, I think we have good experience with this double stent, that it's much stronger than the others. I mean, most of the other balloon expandable stents that we've used in that setting will just crush. But even for fenestrations, I really like the BEVAR plus when we do it in the celiac, because it seems to be much more resistant to that diaphragm crush.
I totally agree. And actually, one extra note more for you than for the audience maybe, is that with all our experience with inner branches, interestingly, we see that the BEVAR plus is doing much better than the other covered stents. So let's see if we
I
can
agree.
get around here. So this is one. Okay, we're in. So saved not by the bell, but saved by the BEVAR plus. Okay.
That's also another good thing about the BEVAR plus. If you use the T branch, like here, or any other branch device, like an inside device or anything, and you're using it in an emergency or a semi-emergent setting where the anatomy is not perfect and the aortic lumen might be small, traditionally we would reinforce these branches that traverse alongside the aorta. But with the BEVAR plus, I mean, immediately you see that it just looks nice and open, and obviously it's two stents. So yeah, for that also, it's very good. It's a good stent to have on the shelf.
Yeah, I was maybe a little bit sub-screening. I was maybe a little bit too safe on the deployment, but I was afraid not to be correct with regard. I should have done another angio to see the origin of the celiac better in the beginning. I'm usually fairly aggressive on putting the branches very near, angiocatheter, very near to the target vessels or the ostia. But here I played it a bit safer than normal.
But this is one of the drawbacks of a non-custom aortic body, I think, is that you tend to deploy a little farther away from the targets than you want in order to get it to fit. And so you end up using longer stents than you want.
I agree. And in the custom-made product, you always know which branch is planned the closest to the target vessel, and then you focus on that one, because then you know the others will be fine. Apneu, bitte.
Exactly. So I think there are some trade-offs to having these non-custom off-the-shelf devices, although they're incredibly helpful.
No doubt, absolutely. Pros and cons, but you have to know your arguments. You have to align your arguments to know exactly where you are. Okay, well, the rest is being fed. I should never have done this branch with a CM, but I did it. It's okay. The hepatic, as we said, comes off the SMA. We can go back to that mosaic. We can go back to that angio, Gematsu SMA angio. Pneu. SMA angio, links. So here you see the collaterals going up to the liver, and in the final angio you see the collaterals going up, and in the final angio we have it too. Okay, durchleuchten. So the good news is we can go into AP, and then we can continue. So if you want to, nein, es ist kein Studiencent. So if you want to continue a discussion, we're gonna reposition ourselves and then do the renals. You can come to us anytime.
Well, I think what we'll do is we'll keep watching you, but perhaps take a couple more questions from the audience, if that's all right with you, Eric.
Screen. Absolutely, absolutely.
And I think one of the questions that someone asked earlier was really about the brachial axillary approach, and if we're not using a femoral approach, how you do it. So Tim, why don't you give us your kind of approach to the upper extremity access?
Yeah, so if I decide to do an upper access primarily for all these branches, our standard is to use the right arm, because that's what we're comfortable with, and it gives us the lowest radiation exposure in the operating room. We'll typically do it from the axillary percutaneous and use probe glides or pro styles if you want to enter. And then put a 12 French 45 sheath across the arch and just leave it there, park it there, so we have as little movement as possible across the arch during the case, because I think that really creates a lot of problems with cerebral emboli. And then through that, we typically would use a 10 French 70 centimeter long sheath to go through, depending on a little bit of the length of the patient. If it's a short patient, the 45 cm might actually be enough. And sometimes you need like a 1080 sheath to come down. And then we use that to work with, but basically leave that 12 French in place the whole time. And then, the steerable sheaths, I haven't actually used when I use an upper access. You can potentially do that as well if you have the long ones. If you go through if you have a 45 as a baseline and use a 70 centimeter like Eric is doing here, to go from the arm. But I normally use standard catheters. My favorite catheter from going up is just an MPA catheter to catheterize the branches. And then typically, if the anatomy is favorable for a cranial approach with all the vessels downward facing, then that MPA catheter will find your way into the branch. And then I will typically catheterize the target vessel secondarily. So I'll get the branch, I'll move my 10 French into the cuff itself, then catheterize the target vessel to get that stable position. And from that, it's just standard stenting. And then when you close, what we've done before is to come from below and get a balloon up into the axillary artery, close the probe glides. And if there's leakage, you can inflate a balloon, potentially place a stent. We've actually gone a little bit more to using a radial approach on that right arm, to stick a radial approach and then use a balloon from the radial up to give some occlusion. You can use a 6 French from the radial to place a covered stent if needed. So that's what we typically do. Unless, of course, it's a very steep arch, then we would sometimes go from the left side instead. But it is a little bit cumbersome to work from that position ergonomically for the operators, as well as from a radiation point of view. So yeah, and what do you do, Tara? What do you have for tips and tricks for the upper approach? Because you seem to use it more.
I think honestly, my approach is reasonably similar to yours, except I probably use the left a bit more frequently than the right. And for no good reason, actually, other than I'm slightly scared of stroke risk, although I haven't, that's never kind of played itself out in data that I've looked at in my own practice. But I agree, the downside of that is that the radiation dose to the operators is really horrible. And I think I haven't quite perfected how to do that well. I noticed that Eric... Yeah, go ahead.
No, I was just going to say that sometimes we were discussing these emergency cases with the T branch when you tend to end up with much longer branches. And in those settings, sometimes I go directly to a brachial or axillary approach, because you often end up using perhaps viabonds or something if these branches become excessively long. And then it can be quite challenging to work from below. In doing that, I find. So sometimes it's a little bit straightforward. And I think, again, as I said before, I think it's good to work from the femoral, to have that as a baseline, but you shouldn't be scared to use the most appropriate approach for the individual case. I think one case doesn't make you to radiate it. So.
Yeah. Now, I would argue that Stéphane Holland from Lille 10 years ago made the argument that that going from the brachial approach allows you to restore flow to the legs a little faster and decreases your risk of radiation, or sorry, your risk of spinal cord ischemia. So where did that argument go in the last decade?
You were talking about Stéphane, the teenager. That's right. Yeah. Okay.
Yes, in your youth.
Exactly. No,
the wine is more expensive now too.
Meaning that we still have in mind to restore flow to the lower limbs as soon as possible, and that is why we actually have one limb, one side with no endovascular stuff in when we access the branches from the other side. So it means that we have flow to one internal and to one lower limb during the time we are accessing the branches. So this is very important. This is a step included in the workflow, is that once the endograft and the limbs have been implanted, we close one side and then we take time to do the branches from the other groin. Another important step is that we are actually quite fast in doing those procedures from the groin, faster than from above. So that's why I'm a bit less concerned with those never-ending procedures where we had large sheaths in both groins for hours. Something else is that we are now whenever possible, staging those procedures to precondition the spine. So exactly like Eric showed us in this nice case, challenging case, he first did a TEVAR and now is doing the branch approach. So this is again a reason for that will reduce the spinal cord ischemia and risk. And the final thing is that we are also quite aggressive with the Missachi approach, which is co-embolizing the trunk of the intercostal artery, staging those co-embolization. And let's touch wood, but since we've been doing that, we've had no spinal cord ischemia for the maybe almost 2 years now. So I know that next week I can have 2 spinal cord ischemic cases, and then my numbers will look the same as used to be. But currently with staging, with Missachi, with obviously all the other adjuncts which are keeping the hemoglobin level above 10 or 11, keeping the mean arterial pressure above 85. I'm quite aggressive now with glycemia also. We give them insulin if needed. And if you add all of that and doing most of those procedures under local anesthesia plus sedation, we can check and do a spinal drain only when required. All those little steps have made us change, and that's why from a real concern regarding spinal cord ischemia a couple of years ago that you were quoting, we are now less concerned if we really stick to the plan.
Great. Anything further to add, Tim, or does that echo your sentiments?
No, I think Stéphane is absolutely right, and I agree with most of what he said. And I think with the femoral approach, I think it's several of the aspects that you mentioned. I also think that when we do this with this 8.5 heart span, basically what we do is we implant everything, and then I put a 12 French sheath in the groin and just cinch down my prostyles. So then you have a 12 French in the groin. So the issue of no perfusion in the limb is no more if you don't happen to have occlusive disease or something. So normally it's done 12 French as opposed to used to be 22 French. And then basically if you're 12 French and working through that 8.5 French heart span, you have all the time in the world. That patient's not going to have reperfusion issues. You know.
So you say you have all the time in the world, but one of our very astute audience members has asked, what should be the cutoff in terms of your skill set? How long do you think these cases should be in order to keep the patient safe and to offer them a good service?
And I think that's a difficult question to answer, and it depends. I've always been surprised that if you have cases where you actually have implanted these grafts and you have flow to everything during the procedure, lower limbs, everything is perfused, you have a lot of time. I think what stops me is that you get tired and you get a lot of radiation, and that would be one aspect of getting out. But the patients actually don't do very poorly because the time itself is very long. It's not directly transferable from open repair, where if you have a big open incision in the patient and they're open for 10 hours, that's a disaster. But here, when you go percutaneous, or when you do it in this stage, I don't think. But having said that, I think one of the good things about endo is that you can stage. So unless it's a rupture or you're really in a bind, you can do it, and you say this is taking more than 5 hours, or whatever it is, depending on where you are in your learning perspective. You can actually choose to step out and come back. So for me, that's always been the advantage. But it's hard to give. I mean, there are cases even now that you look at, this is going to be a long day.
Yeah. Stefan, do you have a number in your head about how long is too long?
I think I'd like to echo what Tim was saying at the end, is that at one point, if you're really struggling, it might be a good option to stop, because you always have the opportunity to come back from the groin or from the top, but you don't want to keep the patient in the OR forever. It's not going to result in good outcomes. So most of the cases will fly, but obviously when you're pushing the envelope with tortuous aortic anatomy, with the disease, the target vessel, if you add those challenges, you might end up with a long case. It's really not often, but I've already took the decision to stop a case, for example, for a renal that was really challenging, and decided to give the patient a couple of days to make sure that he will have no renal issues, and that we could give him some blood to keep his hemoglobin level at a good level. And we came back and did successfully what we, for a reason that I could not understand, were not able to do at the time of the initial index procedure. So this is one or two cases on top of my head. Usually they just fly, and flying means skin to skin of less than 3 hours. But it really depends on who you're treating, on the anatomy, on the challenges associated with the case. Having said that, some of my cases last for 5-6 hours. So I'm not showing off. I'm just saying that easy cases fly. A more challenging case will take longer. And if it takes too long, just stop. That's one of the beauty with endo, is that you can stage, come back.
And I think that's one of the things that we delude people with when we show canned cases, is that we show how quickly they go and how nice they go. And it's important for learners in the field to understand that, first of all, it took all of us a long time to get to that point. And also that not every case, even when you're an experienced surgeon, not every case goes that well. And what I found is I have a point somewhere between 4 and 5 hours into the case where, even if I'm going to keep going and persisting, I make sure I give my team a break, because I think that some of the errors we can make during those cases really come down to human fatigue. And it's important to recognize that the rest of your team needs to go get a bit of candy, have a drink of water. And we're lucky at my place that we have enough people around the table that we can give people a break. And I think those human factors, like being sensitive to those human factors, is important in these longer cases.
Another thing I think that's important to spend some time on when you do have these long cases is, I always tell the guys here on the team that if you go into a case and it becomes extremely difficult, and you knew that this is going to be extremely difficult, or that renal that Stefan mentioned, that's going to be painful to me, and it is painful, then that's okay. But if you go into a case and think it's going to be 3 hours, it should be about 3 hours, 4 hours. It shouldn't be 8. And then after the case, you should probably sit down and say, okay, guys, what happened? Why did this go wrong? And I've actually taken a point now, because you know how it is. We always, as surgeons, blame anesthesia because they're too slow. And they always say that vascular surgeons underestimate the time of procedures with about 50%. So I make a point of with the team to actually on the board before we start say this is going to be, you know, ballpark 3.5 hours, between 3 and 4, or between 5 and 6, or between 1 and 2. Not to show off like Stefan saying I can do these in 3 hours, but to come out of the operating room and say we knew where we were going, we did what we thought we were going to do, and it worked out the way we thought it was going to work out. And I think that
setting
calibration
expectations
is extremely important. It's extremely important. And you know, every case. Yeah, sorry.
Oh, sorry, Tim. I was just saying setting expectations is very important. A team approach is very important, getting everyone involved. I was looking at Eric, and when he first inflated his first BEVAR Plus, I said, oh, I don't think there's enough overlap in the branch. And the next step, next thing he did is actually made sure he had a complete overlap. So that's very important because you have to be how would I say, obsessed with perfect technical results. Because if you want to have a good long-term outcomes, you have to do it right all the way at the top and at the bottom. And something that a little trick that I like is that when I do my selective angio to check that my renal is patent, I get the Rosen back so that I make sure that I have nothing stiff between my bridging stent and the renal artery, because sometimes everything looks good during the case, but on the post-op CT you see a kink. It's just because this Rosen wire had showed a false view of the anatomy.
Yeah, I think that's really true. Now I noticed that Eric has...
I think
sorry, go ahead,
also
Tim.
that goes back to the fatigue issue. I think when you get tired in a case, you ignore details. So you look at these small imperfections in the branch, or you know, that little kink, or moving the wire back, and you're thinking about the fireplace at home. You really just want to go home. You want to get out of there, and then you go too fast, and that's when mistakes happen. So another reason to slow down or turn over the team. We're often two in the operating room when we do this, and that means you can take turns. So.
Yeah, and I can't speak enough to the fact that it's important that you have a team that's fungible, I suppose is the word, that can interchange primary operators every once in a while, just to give each other a break, because that fatigue, like when you're in a state of flow, I agree with Stefan, when things are going well, time flies quickly, but when you are stressed and challenged, you really do need a bit of a mental break every couple minutes or every couple hours. I think we should rejoin Professor Verhoeven in the endo suite. Eric, I've seen that you've successfully stented your left renal.
Yeah, let me show that. Well, I hope you were able to stop screening to have a quick look or to continue to look with one eye. Können wir die linke Nierenarterie zeigen?
Well, I think we've seen it, but the audience hasn't. So please go through it again.
Okay. So gehen wir zur linken Nierenarterie. Nein, bitte, die Mosaik und runter. So, ganz und rechts, ja. Ja, zeig mal, was das ist. No, the next one, nächster. Yeah, this one. So this was the angio to prove that we were in the renal artery. We got into the branch fairly easily. And this is mainly because now suddenly we were able to orient our fusta, and then catheterization is easier. Next, and then we put in the Rosen wire, decided, Stefan showed it. This was just for the lateral wall. I didn't need another angio to have a better angio. But we decided to stick with that, and we positioned a distal B graft plus first. And as Stefan alluded to, we were just a bit short, but I wanted to be 100% sure here. So I decided to go a bit deeper into the renal artery and then put another B graft 638 on top of it. And then we have the control angio. And this is the control angio of the kidney. And now live, we are in position to do the last vessel, which should be the one where we are fairly near to, but the orientation is not perfect because the vessel is about at 9 o'clock, 9:15, and the branch, of course, is at 10 o'clock. Let's see what we have. Gegenhalten. Nicht runtergehen lassen. Das ist wichtig. Okay. Good. Wie viel ist die ACT? Danke. So let's see if I can turn my screen. Oh, my wire is far away. Sorry. Sorry about this. Okay, so we're in there. And that is thanks to the orientation of the Fußstar. Also, you can see from the ring that we are a little bit to the top, which is...
We can't actually see the rings, Eric.
We're not looking at your...
Sorry, I meant the ring of the Fußstar. I meant the ring of the Fußstar.
Oh, sorry. Okay.
That the orientation is not perfect.
So I'm not familiar with this Fußstar sheath. I like the name though. Do you guys use it?
Yeah, well, I would love to have it in a that's about the entry of the renal here, just a bit high. There it should. It's not a bad sheet, but the problem is it's a 10 French, and I would love to have it in 12 French. Then I would certainly be, this can't be the renal artery.
I'll have to see if we can get it in post-Brexit Britain.
That's it. That's it. Okay, let's go back in AP to follow the path nicer, but we are inside. Screen. Well, let's see what we have there.
Wunderbar.
Can I see the renal artery again? I always look at the CT scan during a procedure.
It is very important what you just did to switching back to a position where you can see your wire track into the renal artery, because when you're in this lateral position, sometimes you're already very far into the renal artery, but you don't see it. So that's very important what you just did, Eric, to avoid making holes in the small distal branches of the of the kidney.
Okay. So thank you, Stefan, and I agree. We did a little quick fluoro shot. You can see it again. Kannst du es noch mal zeigen, bitte? Or maybe you can still see it. And now, Rosen. Now we're going to insert the Rosen. You can clearly see where the renal starts. And actually, is Mr. Richard there?
Yes, yes, sir.
Can you show the ring, the fusion for a minute?
Yes, I will do it.
Thank you. I have to thank my whole team for this because it's a lot of work and a lot of concentration in a foreign language, and the people are really helping me a lot, and I'm very grateful for that to everybody. So you've seen the rings, I think, so the fusion works very well here. Now, the only thing is, are we going to go naked? Because I think I would probably. The renal artery, kannst du das mal vergrößern? Die ersten 2 Zentimeter. What is?
So Eric, sometimes the renal branches, which are only 6 millimeter, can be a little bit of a pain, and sometimes you can have a conflict between the bridging stent and the and those small branches. But you never know. You never know. It might just track nicely or not. That's the question mark.
Well, what you see here, Stefan, and thank you for that. What you see here is that we are 658 direkt über die 7 French-Schleuse, die kurze. What you see here, I must say that today I'm a bit fed up with the difficulty to go through the 7 French sheet and the Fußstar 10. And we saw from that other sheet I wanted to use for the first time that it's not guaranteed that everything works. We have other sheets. We have the hard spun in the house. We have the 12 French ANL. We have the 16 French aptus sheet. So we have options, and I haven't found the ideal option. Here, when you look at the wire, you can see a little kink in the wire, and I need to stay just above that because that's where the renal artery is making a turn. And I'm checking this on the CT scan in AP and with the fusion and the part of the wire. So I should be fine with one stent here. Screen. And I'm a bit, to be honest, fed up with the difficulties to go around. And I'm not done yet because even here, it's more difficult than I would expect.
That is very nice, and this is thanks to the profile of the bridging stents.
Absolutely, they are doing very well, no doubt. I think we are. Stop screening. I think from the fusion, Mr. Richard, can you show the fusion again?
Yes, it's still
You can see it.
You can see the fusion. So let me go in AP for a sec. Screen. I think we are fine enough here. Is everybody happy? We may advance just one mu. Okay, screen. That's my famous mu. I always like to move one mu. I think. Okay, that's it. That's it. Okay. Okay. Angiokatheter dann bitte. Well, there you see the ostium. So we are nice 2 centimeters inside. So that's fine.
That's great overlap.
Okay, so I think I'm happy with this one. Okay.
Great. Mr. Richard, we're going to ask you to take that fusion away now, if you don't mind, and show us the team again.
Okay.
Yeah. The problem with this very friendly man is that he has 2 names that can be quoted as first names. So sometimes I say Horst to him, sometimes Richard, and I don't remember which is the first name and the family name, so to speak. I hope he's not angry with me.
Interesting.
For us outside Germany, Richard sounds better.
Exactly, in the English language. But I think if I'm correct now at this stage of my procedure, Richard is the family name.
Oh, Entschuldigung.
Like a great Canadian hockey player. Well done.
Yeah, exactly. Ja, eine Apnoe bitte. And this is one tick of me. I always use the same angiocatheter for everything. Straight one.
And I think something that I always learn watching you operate, Eric, is how flexible and dynamic your plan is. So you go in with a really well-planned case, but you also have like a ton of backup plans if any step goes wrong. And I think that really what sets the greats apart, all those backup plans.
Thank you. Well, Tara, thank you very much. But obviously, to be honest, and also like Stefan says, it's not to show off, but it's really, you know, this is our life. And we've been doing this day and night I've done this now for more than 20 years. I did my first fenestrated case in 1999 with Michael Lawrence Brown and John Anderson. I'm still grateful to them.
When you were 15 years old.
I was not born.
You're such a lovely girl.
Eric, can I ask
before I was born too.
Can we just look at the case before you start joking about Eric's age? He's only 42. He's a young man still. Stop being pesters. Could you just show that renal angiogram again? If you would, the last one you did.
You saw the little kink? Yeah, the angio.
Yes, exactly. And I also noted that you didn't mention it.
No, but
are you concerned?
I mentioned it. No, I mentioned.
Oh, sorry, I missed
wire. He lets the angio. So yes. So if you look at this, we are with the stent before that kink. This is a natural kink We're not
Okay.
going to change this. I saw it on the CT scan. I saw it. Kannst du
Okay,
den Draht
nice.
noch mal zeigen vorher? I saw it on the wire. You see the catheter here. And
Because I didn't see the
den
pre-op
Draht
CT that well, so
No.
I was wondering
I
if that
knew
was
there was a
natural. Yeah,
natural
okay, good.
angle there,
Nice.
and that's
All right.
why I said let's stay away from there. Screen.
So where possible, you try
That's
and
good.
leave the natural angle without a stent in it.
Exactly. I wanted to stay in front of it.
So my
Nice.
comment was merely that if you don't have an angle there and you actually create, sometimes if the vessel is very flexible, you can create that angle with a stiff balloon expandable stent. So if you, just to the audience, if you don't have a kink from the get-go, you put that stent in and you have a kink, then you should probably transition it with something more flexible in the distal end.
Just a
You
moment.
agree, guys?
Yeah, absolutely. It's rare that we use those flexible distal stents anymore, but you do need them every once in a while.
Yeah, and
Now,
that's again coming back to performing the selective angio the way Eric does it with no stiff wire in position, because then this is how you actually depict those kinks. And we have a various short 19-hole stents available to reline that if it happens. Having said that, this is not very often that we need to reline them. If we really nicely look at the anatomy the way Eric did and land the bridging stent precisely where we intend to land it.
Yeah,
and
I remember in the old days
helpful to do that.
Yeah, when we used to use Jomed stents, you know, the ones that you had to crimp on the balloon yourself that are now off the market, those always required a bit of a balloon expandable beyond, or a self-expanding beyond.
Self-expandable.
So I'll take this opportunity to ask an interesting question from our audience. What do you really need to change in your gearbox, so to speak, or your ancillary equipment in order to transition from a brachial or axillary approach to a femoral approach? What are some of the tips that you would say people need to acquire? Cameron, Stefan?
Yeah, I'll just, not much. I mean, you need to have one or two steerable sheaths that you're happy with. And I use now the 7 French Aptus sheath with the 17mm tip for the fenestrated cases, and I use the 16 French with the 22mm tip for my branch cases. For those branch cases, you will need 1 meter or 125 catheters, 5 French catheters. So the KMP would be the number 1, and then usually a Vinci 3 and a Vinci 4 to adapt to various anatomies. And I will also use routinely an 890 or 790 sheath, depending on the big graft class that I'm going to use. But nothing else, except that obviously when you use those long steerable sheath, you will need long catheter, long wires, and long shaft balloons.
It's a great answer. Tim, anything to add?
Not really. Steerable sheaths, and always have a backup for the steerable sheath, and like what happened to Eric here, in case it breaks. Just because I know in a lot of places where you don't do a lot of cases, you might actually buy equipment for the specific case, and that's a general rule for all endo stuff. Always have a backup. Always don't buy one of anything, buy 2 for the case, and because if one breaks, you're sort of going to buy. But other than that, I think it's actually much easier to work from the groin from a femoral approach, because in most centers, you get away from all the very long stuff. So you can use your standard catheters, standard equipment that goes up to 80, 90 instead of using like 125s or whatever you need from the arm.
Yeah, that's great.
I think something important during the learning curve is the way that you use those steerable sheaths, and you need to learn to start putting some angulation, then turn it to the desired position, and then finish the angulation. Otherwise, you twist them. And so there's you have to expect at the beginning to get a couple of issues during your first cases. But once you get used to those steerable sheaths, they're pretty straightforward.
I found having one that I could play with extracorporeally, kind of not in the heat of the case, was also useful. Like, so getting the rep to kind of provide one for you so that you can really get to use it beforehand is useful.
Stenosis.
Now, Eric, tell me, what's going on?
Well, we are just getting in position now to do the bifurcated graft, and then we need 2 limbs. So that shouldn't take too long. We can see the bifurcation both on the fusion, and we're gonna use the longest one anyway. And we have good big iliacs to seal, I think, with a 20 and a 16. I need to check that. 20 on the right, 16 on the left. To finish the job, really. The ACT is still 250, which is enough for me. And now we kind of lift our shoulders and make sure we don't make a mistake. So we need to catheterize the contralateral limb in a minute, of course, and then extend with 2 limbs. So we're gonna flush this graft, orient it, bring it in.
This is an important point, Eric, because at this stage of the procedure, you might be exhausted by all the challenges associated with getting those branches cannulated, getting those bridging stents in position, and working with your servo sheath. So you need to stay focused, and this is where the whole team approach is important. So if at one point you've had enough, get one of your partner to finish the case, but you need to have it right to the end, because you can end up with positioning the control limb between the bifurcated and the branch component. I mean, there are many stupid things can be done. So stay focused. I think it's very important second message at this stage.
Yeah. And as I said, you know, I'm extremely grateful to these people being so patient and following and helping. And quite honestly, on the other side, I miss Thanos and Pablo a little bit. I'm doing something, I don't know whether it works. And I'm going to tell you what I use, because the T branch, no, it's not going to work. The T branch is a 22 French. I used the 22 French sheet from Gore, and I never use this. So I wanted to know whether the bifurcated would go in, but I don't think it does. So we're going to take it out. You have your 2 fingers.
It's amazing how having that knowledge of what stent or what sheath goes into what sheath is so important for these cases. It's assumed knowledge, I think, but when you're just starting out, I found that was one of the things I really had to learn. I'm going to shift our attention back to bridging stents for a second, because we have a question from the audience about relining in these branch cases. They say that the literature says stents are relined 60%. I think I would agree that I've seen that quote in the literature. Now that we have all these new BGraft Plus and we've changed our approach a little bit, how frequently do you put more than one stent into the same position? Or reline?
For me, it's...
And maybe that question goes to Tim or Stefan.
Yeah.
I actually, I mean, if I put one stent in and it looks good, I don't primarily reline at all. I mean, so the, you know, if it's on specific indications, you know, if, for instance, if it's very tight, thoracoabdominal T branch, narrow lumen, and you think the stent's going to be crushed, then I might reline just to get to make sure that the mating stent wins over the main body stent graft, if you would. But again, if you use a BGraft Plus, that's rarely an issue because it's strong enough in of itself because it's already 2 stents. So I think I very rarely reline stents except on specific indications. Obviously, if I see that it's crushed somewhere, if it's not strong enough, going into a stenotic ostium or something, or we discussed the kink distally, but that's not so much a relining as an extension of the stent proximally and distally. You want to make sure you get the whole distance in the cuff proximally. So if you're a little shy, you might put another stent in to make sure that it sits and so on and so forth. But to reline the men's center, I don't do that much.
And so I'm on the same line because it's rare that we need to reline them. What happens is if I'm too short within the target vessel, but already inside the target vessel for 10 millimeters, then as I said previously, I would actually reline it with a regular B graft to have something a bit more flexible. And if I'm actually far enough into the target vessel and then I have an issue with the target vessel, such as a kink at the distal end of my big graft plus, then I would use a short 19 or stent. But again, this is not routine, and it's probably, I don't know, 10 to 15% of my cases. It has changed so much from the past now that we have dedicated bridging stents.
Great. So Eric,
it's
you put your
interesting with the
unibody
relining.
Sorry.
Just mentioning
Go ahead,
for
Tim.
the relining, I wanted to remember the reference, but we have one of our aortic fellows here from Italy. They've just done a trial on this and actually looked in, and it, I mean, what's the hen and what's the egg? But the relining doesn't seem to work very well. When you start relining stents and putting double, triple stents and things, they actually tend to have higher rates of failure. Now, you could argue that the reason they failed was also the reason they put double stents in, but for any cause, it still didn't work. And there are actually a couple of papers out to state the fact that you see more stent fractures, for instance, if you go in and you place multiple stents, and that makes sense. So I agree with Stefan. Now that we have these more dedicated stents, I feel comfortable not relining, and I actually think it's much better.
Great. Eric, tell us, you've put your unibody in.
Yeah, we just deployed quickly the unibody, stop screening, and now we are going to catheterize the contralateral limb, maybe make one angio for both sides because it's easy iliacs, and then we can hopefully finish the job. Screen.
So have you put your 22 French all the way up
Back
to
again,
the,
yeah.
And why do you do that?
Well, I'm going to pull it down. Well, because, we have purse string sutures, but the other sheet was slightly smaller. Can you hold it for a minute? It was slightly smaller. So I decided I may need a Cobra here, actually. And then we had a bit of a leakage.
So it was an access issue.
Well, it's not an access issue, but it's a bleeding issue.
Yeah.
Let me see if I can get this catheter. Stop screening. I'm almost in, so I may not need the Cobra screen.
I'd just like to give credit to both of my co-moderators who are managing clinical emergencies while doing this. So kudos to them. But that explains why every once in a while we've lost them. I'm grateful for their
no problem. I know Tim is also doing a thoracoabdominal. I heard, I think.
Yeah, well, exactly. Yeah, we're so grateful to have the time and the expertise all concentrated in one morning.
Well, it's especially very nice to be relaxed and to be able to discuss things together. And I hope it's nice for the people. And but the clinical work doesn't stop as usual. Screen, and my people are getting nervous because they want to get the next patient on the table. Okay.
True. Aorta
so
stop for no one.
Screen, exactly. So. Stop screening. Okay, I think that is fine. Can we go down here a little bit? Aber dann gut halten, bitte. Okay. Yeah.
I think we should also take this time to acknowledge that it's International Women's Day today, and for all the surgeons who are watching this.
3 women at the table.
Yep. Aortic surgery is a very accessible career for women. So please, please make sure that you don't listen to the old traditional things, and remember that aortic surgery is great for both women and men. It's a good career.
I couldn't agree more.
We now have
should have
three
advantages.
professors of vascular surgery in France, and some of them trained by Tara and myself. So it is important to stress out that there are great careers for women vascular surgeons.
Yeah, absolutely. And with the attention the field is putting on radiation dose these days, I think it's safe as well, which is something I appreciate as I'm an older woman now.
Vorspritzen. Danke. Okay, so we're going to do a quick angio here. Let's see if we can measure screen. Okay, I'm going to push it. Sorry about this. It's okay. It's 1.5, but it's okay. Okay, hold the catheter. Yes. Eine Angio bitte. Ja. Up. Okay, so we know that we're inside. You would agree on that. Let's have a hold the catheter. The wire. So best image, please. Nein.
So you're both checking that you're inside and also checking the location of the hypogastric with this image. Is that the idea?
Yes, it's 1 in 2 or 2 in 1, sorry. And we use the longest one we have, and we see a big lumbars there. It would be nice to stop now for the paraplegia and then to come back. Screen. Okay, I'm going to come back because my wire is complaining a little bit. Screen. So I think it's making a curve there. Okay, let's go in screen. Okay, that goes nicely. Let's see up there and then have the Amplatz wire screen. Okay, so that is fine. Okay, Amplatz wire.
You know, we talk about this being the easy part of the procedure, the iliac placement, but frankly, when you look at aortic deformation in real time, the iliacs are the most unpredictable deformers of all the other bits of the aorta. And I find that accurate deployment in the iliac is something that's actually quite a skill.
Stay there. Well, it can be
interesting when you look at, yeah, but it's also interesting when you look at long-term data for fenestrated repairs and stuff like that, that actually almost the vast majority of problems occur in the distal. So you have limb occlusions, but you also have type 1B endoleaks. So I think it's completely underestimated, like you say, the significance of this. This is what brings a lot of people into trouble. We're so meticulous with our fenestrations and branches in that segment and getting a proximal seal zone that we forget about the distal part. So yeah, you know, it's getting home safely. Very important.
Exactly.
Okay, so stop screening. So overlay, let's measure quickly. Durchleuchten. Stop screening. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Oh, was haben wir? It's big iliacs and it's still long, so I hope I don't need an in between.
122.
So it seems that a 90 will bring you into the horizontal portion of the iliac and provide a good seal.
Yeah, well, on the left I measured. Können wir das mal sehen? Axial. On the left I measured 13 to 15, but you will agree with me that it looks much bigger on the angio. Of course, it's magnified to the maximum, but I'm looking at the CT scan right now. Stop.
13 to 15 actually, diameter.
Well, yes, it's not that big on the CT scan. Yeah. Haben wir 2 lange 20er? Die 93er? Yeah, give me a 2093 and then we will see. I actually, when I look at the CT scan, it's not that big, especially at the end, but I'm not sure I'm going to reach the end. So let's have a 2093.
93 sounds perfect.
Jawohl.
Kamerad.
Kamerad, yeah. Okay, let's measure the right side because I may want to do the right side first to fix it because I'm expecting on the left side to have to push a little bit. Screen. Stop screening. Okay, screen. Stop screening. So here we go till the bottom, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we need about 11. We always lose a centimeter. And I think a 20 on the right will be. Wie groß ist die, wie lang ist die 93 insgesamt? Wie bitte?
93 plus 28, 121.
So we've had a question about foreshortening in branches, and I'm going to extend the question to iliacs because I noticed that Eric made the same calculation as I do, that you always lose a centimeter. How do you judge foreshortening? How do you decide when you need that extra length of stent? Does diameter make a difference?
It's a difficult one because the one thing I know is that whatever you measure on an angio and via catheters, it's always too short. So you always have to add up about a centimeter, sometimes even more. Gib uns auch noch, wie lang ist die 2077er? For the iliacs, you know, give me that one. Yes, we can play a little bit. So it's a very difficult thing to measure these angulated iliacs, and I'm sure it's going to be much longer. But as I said, I have a view on the CT scan, and in the axial image, and I see the iliacs go really caudal, and they are very long, and they are fairly uniform in diameter. So we should be fine, hopefully. But on the left, I'm going to take a bit wider than I measured. I measured 13 to 15, and then it goes down again in diameter. But I think a 20 on both sides will do. Maybe the magnification is too high. Well, how do you do it, Tara, with the iliacs? Do you stick to your measurements before?
I take measurements before. I know what I'm expecting so that I'm not surprised, but and so that we can make sure we have the right devices on the shelf. But I usually kind of do an assessment on the day. Diameters don't tend to change, but lengths are different.
And what I always advise Cook when they do fenestrated somewhere else, obviously we have all the limbs available, but always have 2 lengths of limbs available to choose from, because I think that is very, very important.
Slightly more challenging these days as it's harder to get stents.
I also think it depends on which grafts you use and what limbs you use. I mean, some devices are easier to stack or to adapt to anatomy. And Eric, you know that for sure. With you've used a lot of Gore devices. You can really push those into a curve to adapt. So even if it's long, you can get it shorter and so on. So it's a little bit depending on what device you use as well, I guess.
So we are fine here. Sorry to interrupt him. We are fine here with regard to length with the 2077. And I'm going to deploy it like this. Screen. Okay, Coda balloon. Yeah. Yeah, see. zie je alles. Ja. Ja. Oké. And Tara,
Yes.
regarding radiation, I think the main operator, whenever he can, should do the table and the screening or be in charge of the screening to make sure that we don't screen senselessly.
Yeah, oh, I couldn't agree more. And I'm so proud to see the leadership in the ESVS radiation guidelines actually mention that, because I think it's a bit of a point of contention in some areas about who's allowed to touch the table. But there's no question that it's way better if the surgeon does it.
Stop.
Bravo to Professor
the
Verhoeven
operator.
for that,
actually
the operator.
And there is real data to support that. I mean, you reduce radiation by having a full control at table side from the main operator. So I'm 100% in line with both of you. This is something very important. Having said that, I know that in some places there's a lot of discussion between the various teams, radiology, surgery, with the techs, and it doesn't make sense to spend the 2 hours to position the C-arm or the table just because you're not the one in control. So you need to have, and also I see that you're using collimation, that you're using a low dose protocol, and you're limiting the number of DASA runs. By having some fluoro runs, all that makes a huge difference at the end of the procedure.
Okay,
definitely. I would definitely point the interested audience member to the radiation guidelines by the ESVS. I think they're a brilliant document. Well done. Are they published yet, Stefan?
Just wait a sec.
No, so we are the last submission is in this week or the following week, and so we can expect them by this summer.
Oh, wonderful. Well, it'll be good
also the online
for all of us.
The online radiation courses from the SCS are also very excellent, both for staff and for junior colleagues. They go through all this. It's a very, very good online training.
Dan bitte Finger drauf.
Who are involved making that.
Du stehst da, also du sorgst, dass das nicht liegt. Rechtes Bein wieder offen, Anästhesie, grünes Tuch. Nicht zudrücken, aber abdrücken, bitte. Okay. We've molested a little bit the right groin, must I say, so with all these sheets going in.
Lost in translation a bit.
Sorry, I mean that it's leaking a little bit from the right groin.
Yeah.
So the purse string sutures don't work perfectly, but with these big sheets that we've used, it's logical. Okay, can you push hard, Elena? Okay, yeah. So on the left, as mentioned, we were percutaneous. So we're gonna hold the wire. Okay, I'll hold the wire. Make a loop. Loop.
And I missed that, but Eric, why did you choose to open the right groin?
It was a redo, and we already went in with a big sheet. So I decided also for safety to have a perfect open approach. In addition, as you see, it's calcified and angulated. So we decided to play it safe. I'm not, last close. I'm not, how do you say, I'm not stubborn in everything we do. Screen, hold the wire. We can do both, coming from above, coming from below, durchleuchten. This is what I expected. And that's why I decided to do the right limb first. So now we are in, which is fine. Okay, I'm gonna push the pusher against. So stop screening. So as you see, the angulation and calcification are a bit of a problem in this guy. And that's why I decided to do this screen. Let's I think we are absolutely fine with regard to length. Pushing up just a little bit without making folds. Okay, good. Stop screening. Okay, take it out. Hold this, please, with 2 hands. Yes, I'm holding it too, but
The way that limb open, you are 100% sure you're not covering the hypogastric. And I think in those thoracoabdominal cases, you don't want to take any risk. I mean, never play with the hypogastric. Otherwise, it happened to me once. Actually, at the end of the procedure, I went through a retroperitoneal approach and did the bypass between the external and the internal, because you so much increase the risk of spinal cord ischemia by covering a hypogastric that you have to do everything possible to keep them open.
Yeah, and if you're tired after a hard case, that is not fun to do.
And if you inadvertently do that, you can actually go crossover and use your laser and make a little hole in the graft for a little fenestration for the hypogastric. I'm not saying I've ever covered a hypogastric, and I've never done that, but potentially you could. Actually, not a bad thing. If you do have a laser, you can actually quite easily do that. So.
Especially because you have your steerable sheath still on the table, and because you need support when going up and over in those endograft, and then you would use a 0.9 millimeter laser probe.
So I would use the small one. So we typically have the 14,000 laser probes because they don't deflect the sheet that much. But I think when you go crossover, you could probably use an 035, so a 2.3 if you wanted to, because it's going to be stable enough. The easiest way is to use either a steerable sheath or just a 12-frame sheath and hold it through and through, and then you can just go down with your steerable sheath to the entry and poke a hole. And obviously, in some sense, it's still a bit safer to do it with the 14,000 wire because you're not making a big hole if you miss it. So you can poke several times if you want. So I think
it's a very important point, and that's why I prefer to go with the small one. So the case I was quoting was before I had access to laser. And laser is also a game changer in the endovascular world. I think we've used it a lot when in trouble or as planned procedure. It's one of those ancillary tools that makes a huge difference at the end of the day.
Absolutely. So it's completely abolished the use of emergency chimneys for renals and in emergency cases for us. Either if they're covered or just de novo and ruptures, I will just place a graft across and just make a hole. So yeah, real game changer. That in combination with the steerable sheet. So.
And Tim, maybe for the iliac, you don't need to go up and over. You can go on the ipsis side to make your fenestration for the hypo.
Yeah, you could, depending on the size, of course. Again, if you have one of the small Aptus probes, that I think the smallest curve is like, I don't know, but sometimes the curvature is a little bit too wide. So if it's a 12 millimeter limb you've put down, it's too narrow. If it's a 24, you might potentially be able to do it, but it's actually easier to go from the other side.
9.
And I think Eric is getting ready for his.
Yes, we are doing the.
I was going to say, Marius, let's have the next live case with a laser fenestration for a short neck or something like this. Big rough cuts are really nice in those setups.
Stay tuned, folks. The Bentley series is getting more exciting.
Well, Eric did a great job here. He really pushed the envelope with the challenging case.
It's true. I agree. This was a very difficult case.
Well, not everything was difficult, but we struggled a bit with the upper approach, with the lower approach. And maybe it's also due to the calcified iliac vessels. So it all comes, as Stefan said, it all comes together, doesn't it? Kan je een beetje nog voorwaarts? It's angulation, it's calcification, it's size of the vessels. But never expect these cases to be easy, because the day you think, oh, this is an easy case, you can also make mistakes. Count your blessings when it goes well, and be prepared to have a plan B and C, or to
Wise
be flexible. Good, let's see where we are. I don't think we need to go higher because we did that before, but we need to see the overlap there. We're gonna have 2 angios anyway. Screen. Okay, stop screening. Ja. Gut, eine Apnoe bitte. Thank you. Up. Well, that's not too bad, pneu, except for the type 2 endoleak in the bottom for sure. But let's see what we have, and feel free to criticize, but I'm always very tempted to be very careful here. Well, I see all the branches, that's already something, but at the end it fills dramatically. But it seems to come from below upwards. Okay, screen. Catheter was far too high, I apologize.
And the image quality on my computer is not perfect. Did you see nicely the branches of the SMA light up?
Yes, all the branches of the SMA were very nicely seen. That's not a problem.
Perfect.
I think the branch portion looks great. I agree there's a distal endoleak, but I think it was hard to adjudicate 2 versus 1B.
Yeah, well, let's see. We're gonna do, yeah, that's what we're gonna check now for sure. Screen.
But don't forget that you're under high dose heparin.
Oh yes, oh yes, of course. We know that. We've seen those images before. Okay, nochmals eine Apnoe bitte.
Kliv av en gång.
Thank you.
Bara kliv av, låt den vara bara.
Up.
Professor Resch, maybe you want to go on mute?
Sorry, I'm trying to direct the case in the background.
No problem, Tim, no problem. So let's see what we have. I mean, we may have a little early blush there. Do you think we overinflated something? I mean, distally looks good, actually.
Isn't it a type 3? You think it's the overlap between the T branch and the BIF?
But it shouldn't, should it? I ballooned
because
it.
if you pull, so if you yeah, but sometimes if you pull, if you shoot an angio inside the bifurcated device and not with the overlap, will you see this still? I don't know.
The Eric, how much overlap do you have? How much stents?
3 stents.
I think at this stage, and this is what part of the discussion we had previously, at this stage, I would finish the case and shoot a CT scan in a couple of weeks. And if you need to fix anything, fix it as a second procedure. But I think everything looks perfect at the top. Both kidneys are nicely perfused. The SMA really looks good. And
well, I hope we didn't over balloon something and created a little tear. But it looks very much like at the end of the tube and the bifurcated. I could balloon this again, of course, but I'm afraid of over ballooning it. We have 3 stents overlap. I can clearly see it, and that should be enough.
You know, if it's a type 3, I would just leave it. I would just, like Stefan says, get out. And the only reason I would verify if it's type 3, so it's not the iliacs look fine. There's nothing distally. So you're left at being either type 3 or type 2. So then I would agree with Stefan. I would probably just leave it.
Yeah, reverse the heparin.
I agree. I'm not
live to image.
Yeah, we're gonna do that right now, and I think I would also be very inclined to say that's it for now, and let's follow it and do a CT scan and then see how it looks. We've seen such things disappear completely in most of the cases, quite honestly. And
because
actually,
it really looks like the overlap between. It really looks like it's the overlap between your branch graft and your bifurcated graft. So this will obviously seal because it's graft against graft, and
but it's
I would
3
not be
stents overlap. So it's 3 stents overlap, and I think indeed it's type 3 between tube and bifurcated.
That should be fine.
So
remember,
let's call it a day. Give protamine and see how the patient recovers, and then do a CT scan. Of course, look at it. But it wouldn't be the first time that we see these things disappear completely. And the interesting study would be the patients that have perfect completion angiograms versus patients that have this, whether they do worse. But I'm going to stop now, as you suggest, and as I completely agree with. Thank you very much. We're going to close it up. And enjoy your discussion. If I'm ready, I will come down, but I don't know how long you want to go for.
Bravo. Well, thank you, Eric. Congratulations to you and the whole team.
Fabulous.
Thank you very much to
Fantastic
all of you.
case.
Bye-bye.
Congratulations, Eric.
Well done. All right. So any final thoughts on this case, on Stefan's case, and anything that you feel like we haven't discussed?
I think it was really interesting to see Eric's case and to comment, and it's nice to be sitting on a chair and giving advice. But it's much more challenging to be doing the type of case live. But it shows you that with a cerebral sheath and a good bridging stent, that you can tackle with experience those difficult anatomies from the groin. And I think we've learned a lot. I was really happy that we could have this very constructive discussion. It seems that we kind of are all in line with the way to perform these cases, and I think one of the main take-home message here is that we have now dedicated bridging stents for those procedures, and this makes a huge difference. So I was really happy to be part of that and to have this discussion with you guys.
I also think it's you know, a great case. I think my thoughts are that, you know, we're all now exploring this transfemoral approach with some success. Stefan says he's done most of his last 3-year cases like this, and I think that's the way we're going. It's interesting, I think, for us who've been part of this game for a very long time to see that once again we had just established a very firm platform for doing our branch cases from above and doing our fenestrated cases in a certain way, and now with the steerable sheets and the new stents, everything changed again. And for the transfemoral branch approach, we're still looking for some improved equipment, but you know, I think we're getting there slowly. Some improvements in the wires, some improvements in the steerable sheets, and further improvements in these already very good branching stents. And I think this is the way to go for sure. So yeah, lots of. I'm always amazed at how much you learn from a single case.
So true. And the principles are always the same, you know, the attention to detail, supporting the team, keeping your radiation dose low, hiring women. All these things are the principles that never change. And that last comment for people joining us late was just about International Women's Day.
We hire women and nice men who like hiring women, of course.
Yes, exactly. It takes everyone to change society. So I think with that, I feel very confident that we've had a great educational experience here, and I would really like to thank both Bentley and Radcliffe for allowing us to do this kind of surgical education, which is invaluable, as Tim and Stefan both said. And I'd like to thank my co-moderators for managing their busy clinical schedules and also participating in this, because your contributions were invaluable. And so I wish everyone a lovely afternoon.